Thank you, Dr. Gabbani, for your kind presenting me. Good morning, everybody. Uh, uh, I would like at the beginning just to thank AGU for arranging this conference, which is very useful at the level of the student and even the doctors. Going back to our presentation today, today we are going just to give a brief talk about COPD because COPD is a big subject, as you know. But time to time there are new updates in the guidelines, which we are usually need to emphasize on the doctors in general medicine and even the family physicians. So today we are going to talk about definition and overview, diagnosis and initial assessment, the evidence supporting prevention and maintenance therapy, and the briefing about management of stable COPD and exacerbations, and at the end, comorbidities. We'll start with the definition. As you know, COPD is a preventable and treatable disease, which is characterized by persistent of respiratory symptoms and airflow limitation due to airway or alveolar abnormalities, usually caused by exposure to noxious particles or gases. Now, just going quick about the usual etiology. As you know, around 90% of COPDs are smokers, so it's the main cause of the disease. Beside other pollutants which might present in the air that might cause the disease as well in the villages or towns or cities near factories. Now, what happened later? As you can see, there will be some impaired lung growth, accelerated decline and lung injury, and there will be some systemic inflammation. After that, there will be a small airway disorder, emphysema, and the rest of systemic effects will be leading. Just to have a briefing about the prevalence. As you know, there are around 380 million COPDs in the world. That was a statistics in 2010. And the prevalence is around 11.7%. 3 million deaths annually. And these deaths are expected to rise in the next 30 years. Expected around 4.5 million in the 2030 years. Economic and social burden is very important, especially in the developed countries, and they estimated the cost of respiratory disease over all the diseases around 6% of the total budget in the healthcare system. And COPD takes around half or even more than half percentage of this cost. That was a study in the European Union, and the other studies in the United States state that the approximate cost in COPD direct costs are around 32 billions, and if we added the indirect costs also, it will reach around 50,000 billions. Moving to the diagnosis and initial assessment, to diagnose COPD, it's not a single entity or single test. We have to have the symptoms of COPD, which are the common symptoms: shortness of breath, chronic cough, and sputum. Beside that, the patient has to have the risk factors or exposed to the risk factor. Mainly, I'm talking about smoking and or occupational exposure, especially those who are working in factories. Now, after taking the symptoms which fits the diagnosis and taking into consideration the risk factors, we need to have the spirometry testing to confirm our diagnosis. Here, actually, I would like to emphasize on that slide. This is very important slide, especially during the COVID pandemic era. We used to request spirometry for our patients frequently, just to have follow-up about our patient. But in COVID-19 era, we have to be careful about that, in which spirometry might play a role in spreading the disease itself. I mean, if the patient who is doing the spirometry having the disease and we don't know about it, then he might infect the healthcare worker who are doing the spirometry. So the current approach, what we are doing as a physicians, we are checking the vaccination status initially, and then to check if there are any COVID symptoms. Okay, if the patient is vaccinated and there are no COVID symptoms, we just check the temperature, just to be sure that there are no unknown symptoms to the patients. If all these are not there, then we will perform the spirometry. So this is an important message for our doctor and even for the family physicians in the health center if they have the spirometry. Just ensure that your patient is not a carrier of COVID-19 before doing spirometry. Now, this is the spirometry. As you know, on the left side, you can see the normal ratios, usually are more than 80%. And in the right side, you can see the COPD patient spirometry, in which we can see the ratio should be less than 70%. According to the spirometry, we can classify our patients into the mild, moderate, severe, and very severe classifications according to the gold standards. The mild disease is usually more, the FEV1 usually more than 80%, in the moderate between 50 and 80, and the severe is between 30 and 50, and those who are having a very severe disease, they have the FEV1 less than 30%. Now, we have a lot of questionnaires used to assess our patients, but usually the common questionnaires that we are following is the CAT, COPD assessment test, and the Mmrc questionnaires. Here is the questionnaire of the CAT. There are 8 questions and scoring system according to the patients, and then we calculate the score. This is the Mmrc, as you know, dyspnea scale. Also, we classify our patient according to that. Now, part of our assessment is to classify our patients into the mild exacerbations, moderate exacerbations, or severe exacerbation. These are a very important classification because in mild exacerbation, these are exacerbations that the patient needed to take only short-acting bronchodilator drugs. While he is at home, he will have some dyspnea and he will take a rescue medication, short-acting bronchodilators. The moderate severity of the exacerbation, if the patient needed to take antibiotics or a course of oral corticosteroids, then we need we can name that as moderate exacerbations. Now, the severe exacerbations, usually the patient needed to be either admitted to the hospital or at least visit the emergency. So this is a very important part while assessing our patients, whether it is in the clinic or in the health center, is just to ask about the exacerbations and to classify these exacerbations. Uh, Actually, previously the gold classifications was the main classification that is used in COPD, but now the new ABCD staging system has evolved, and it is the standard used now in classifying our patients. So just to explain the ABCD system briefly, we have to classify our patients who are high risk or low risk. So those who are high risk patients, these are the C and D stages. And those are who are low risk, these are the A and B stages. Okay? And the patients who are having more symptoms are the D and B stages, and those who are having the low symptoms, these are who are A and C stages. Okay, so symptoms will depend usually on the assessment test that we mentioned, CAT or MMRC. So if it is less than 10 in CAT or 0 to 1 in MMRC, then these are low symptom patients. And if the CAT is more than 10 or the MMRC more than 2, then this is high symptoms patients. Now, what patients who are high risk patients? Those patients, those patients high risk, usually they will have more than one leading to hospital admissions, okay? Or those patients who are having more than 2 exacerbations in the last year. These patients are considered to be high risk patients. And if the patient does not have any of these, then he is a low risk patient. So based on that, after the spirometry test and after the gold stratifying, we use the ABCD system to stage our patient. Now, going to the third point, which is the evidence of supporting or prevention and maintenance therapy. The first slide, as you know, we always emphasize on smoking cessation. And as you can see here in this graph, it can illustrate very well those patients who are non-smokers and the decline in the FEV1 throughout the age. So those are who are non-smoker. You can see the blue line, the FEV1 will decrease to reach around 60 to 75% at the age of 80 or 90. But those are who are smokers and they continue to smoke, the decline in the FEV1 will be very steep, and they will reach around 25% FEV1 at the age of 55 to 60. Now, what happened if they stopped? Depends at what age they stopped. So if they stopped at the age of 45, then there is a possibilities of prolongation of FEV1 decline. But if they stop or quit smoking at the age of 65, then still there is a benefit, but not like when they stop it before that. Vaccination is also important. No need to go much about it. Bronchodilators, anti-inflammatory therapy are the standard treatment. This is actually a study was published in 2011 regarding the use of azithromycin as an anti-inflammatory drugs in COPD patients. Rehabilitation, education, and self-management. Education alone did not show any benefit in improving patient symptoms or reducing exacerbation. But if we combine education with self-management and intervention, the studies showed that there is benefits of decrease in exacerbations. Oxygen, quickly, it also showed an improvement in the mortality and symptoms for those patients who needed oxygen. So not every COPD will need oxygen treatment at home. There are certain criteria. If the PO2 partial pressure less than 60 or 55 in case pulmonary hypertension. And this is a graph showing how survival affected by the giving long-term oxygen therapy for those patients. And this is the study which was published in 2016 showing the benefit of oxygen in improving survival. Now, is there any other interventional therapy? Yes. For selected patients, there is the lung volume reduction surgery can play a role in reducing exacerbations and improving the exercise capacity. Bullocktomy also can be used, but in a very selected patient. Transplantation also for those who are indicated. And the new thing is the bronchoscopic intervention. Now, the bronchoscopic intervention has now replacing the lung volume reduction surgery in terms of improving exercise capacity and reduce exacerbations. For the sake of the time, we'll just have a quick points regarding management of stable patient. We usually emphasize and looking into reduce the symptoms and reduce the risk in managing our patients. So, what are the pharmacological treatment? This is a very complicated graph. Okay, so what we do usually, to simplify all this, okay, as we mentioned, the ABCD system, which is evolved recently, has put the groups in different medications. So group A usually they will take bronchodilators only during exacerbations if needed. Group B, they will be indicated for use of either LABA or LAMA medications, or in sometimes if they are not improving, we can combine them, LABA and LAMA. Group C, the preferred medication is the LAMA. And in Group D, we have the options to start our patients on single monotherapy LAMA, or to give them the combination LAMA-LABA treatment, or to give them the ICS plus LABA. Or there is an evolving medicine now which has been approved to be used in Group D, the triple treatment, the LAMA, LABA, and ICS, all in one device. Now, this is the FLAME study, which was a randomized control, double-blind, non-inferiority trials, which was comparing the LABA-LAMA with the LABA-ICS treatment of COPD patient. It showed, 1 minute, okay. I have to go fast. It showed quickly, just to go briefing about it, clearly you can see that there are at least non-inferiority of the use between the LAMA-LABA and the LABA-ICS. In fact, the LAMA-LABA are superior to the use of LABA-ICS. What I wanted to emphasize, and this is one of the things that it is evolved newly, is we have to treat our patients phenotypically. There are phenotypes of COPD. So those are who having high eosinophils are different than those who are having low eosinophils. So especially for those who are having eosinophils more than 300, those patients will benefit much of ICS. And those who are having less than that, usually they will not benefit from ICS. So it is preferred to remove ICS from the treatment. Thank you for your audience, and I would like to thank AGU for this very beneficial conference, and thank you.